Good morning. So I'm going to talk about Shockwave. This presentation normally will take an hour, but I'll try to reduce it to half an hour because we don't have time. So this talk will aim to explain the mechanism of Shockwave and why is it better than the other plaque modification technology that we have at the moment. And then at the end, I'm going to show you how to set up the console and the cables and the catheters. You know, normally our artery is very elastic. You can expand it, you can bend it, but the problem is if there's a calcium in one of the layers, it inhibits the expansion, especially if you deploy a stent. This calcium is situated actually between the layers. So I'll show you anatomy of artery. So it consists of different layers. So the first one is the lumen, right? So it's not a layer, but the lumen. And then the first layer is the endothelium and intima, media, and adventitia. And the calcium is situated around here. So it's not in the middle, in the lumen. And I'll explain the problem with that later on, especially when we use a rotablation. Okay, so as I've said, it impedes the stent expansion, deliverability, inhibits circumferential stent expansion, and as a result, it worsens the long-term outcomes. So the more severe the calcium is, the worse outcome for the patient. And this is one example of the artery that is so heavily calcified. And imagine, you know, putting a stent distally. It's so difficult to put through a stent there, as you can see. So because of the calcium, it lacks flexibility. It's quite rigid. And because of that, you cannot properly implant a stent. And also, sometimes when you deliver a stent, hits the calcium, and some study says that there's it may lead to impaired drug deliverability because the stent is coated with a drug. So when you try several times to pass through a stent, it scrapes the surface and affects the drug delivery. So this graph just shows the more severe calcium in the artery, the less you can expand it. So in here, less calcium, you can expand it up to 18 atmosphere, 100%. But then if there's a thick calcium, you can only expand it for, reduced amount. And that's just what it says. And here, one of the studies, it says that the more severe calcium you have, the more likely you'll die. And with MI, death, or whatever, ISR in the future, compared to without, 4%. Yeah. And also in this graph shows that the more calcium, the severe the calcium is, the more likely you'll, as I've said, die, cardiac death, MI, and whatever. And so I'm just going to ask you, what are the technologies we have to disrupt calcium at the moment? What are the technologies that we use in CathLab? Cutting balloons, yeah. Rotablation. Others? Scoring balloon, yeah. So scoring balloons, cutting balloons, high pressure balloons, OPN balloons, rotablation, lasers, rotational atherectomy or rotablation. In some centers, they have orbital atherectomy as well. So I'll explain to you the problem with these technologies. So with high pressure balloons, I don't know if you can see, in the middle, there's thick calcium there. So the distal and the proximal end of the balloon is expanded, but not in the middle. So the more you inflate it, it causes inflammation to the lining. So sometimes you have a plaque rupture, and of course, when there's a rupture, the normal reaction of the body is to try to heal it, so it will clot, causing more clots in the artery. That's the problem with that. And the other one with rotablation is, so rotablation uses a wire to guide the burr. So as you can imagine, all of these severe calcified arteries, they're so bendy as well. So the wire goes to that, for example, this is the normal right. The wire tends to go to this side, right, instead of this side. So when you insert the burr, it just ablates this side. That's the problem with rotablation. It's wire biased. So as you can see here, this is the short axis of the artery. This white bit from the OCT is the calcium, and in this side is where they rotablated. So, and also this side. So how about this side? So it's not affected. That's the problem with rotablation. It only ablates where the wire is. Yeah. So, you know, if you implant a stent later on, this side only expands and not here. So that's a problem with rotablation. All right, we're gonna talk now about Shockwave. So Shockwave is a technology that was developed more than 20 years ago. They use it in the renal to disrupt the kidney stones. And then the Shockwave machine, they miniaturized this so we can use it in the coronary arteries. By the way, we have two different types of Shockwave catheters, coronary and peripheral. So they have big differences. So with coronaries, you only have 2 emitters. So from these emitters, that's where the wave comes from. So coronaries, the length of the balloon is only 12 millimeters for all sizes, 12 millimeters. And for the peripheral is 60. And the peripheral has more waves or more therapies compared to coronaries, which I'll explain later. So this is the console itself. And it's battery powered. So you cannot use it and charge at the same time, because you can only connect to this cable at one time. And it consists of console, the cable itself, which needs to be sterile, and also the catheter itself. And these are the different sizes at the moment. So the smallest we have is 2.5 millimeters, and the biggest is 4 millimeters. And for coronaries, they all have 80 pulses, and the length is 12 millimeters. And they're all in 6 French size. I'm going to play a little video about Shockwave.
Shockwave Medical IntraVascular Lithotripsy IVL technology uses pulsatile sonic pressure waves to effectively modify both superficial and deep calcium in a safe and reproducible manner. Using standard techniques, the IVL catheter is advanced to a target lesion, and an integrated balloon is inflated to subnominal 4-atmosphere pressure. At the press of a button, sonic pressure waves generated by an array of miniaturized lithotripsy emitters travel through the fluid-filled balloon and pass through soft vascular tissue, selectively modifying the hardened calcified plaque. Following the calcium modification, the integrated balloon is inflated to nominal 6-atmosphere pressure in order to maximize luminal gain.
This emitter emits like a spark, and that spark creates bubbles. And the bubbles, it collapses rapidly, causing a wave. So, and that's how it works. And this is one example of they did in the lab, where they put a like a block of like calcium, and you can see how it will work. So the good thing about this shockwave is it only attacks the solid bits and not the tissue.
Feel it?
So in here, he's putting his hand.
Feel it?
Anyway,
Yeah.
yeah. If you hold it, the balloon, it won't affect you. This is one other example that they did. So just one pulse, and you can see the crack already in the eggshell. So imagine like several waves. So the good thing about this is the waves is circumferential, so it affects circular, unlike the rotablation which only affects one side. So it cracks the calcium circularly. And this is shockwave in action. As you can see, it's really calcified there. And look at the balloon. It slowly expands while the doctor is giving pulses. Yeah, slowly expands. And this is after the shockwave.
Sorry, is 10
Yep.
seconds the standard? How long
Yeah.
the shockwave?
So the balloon has 8 they call it therapy. So one therapy consists of 10 pulses and 1 pulse per second. So when you press the cable catheter, it gives 1 pulse per second. And then after 10 seconds, it shuts off automatically, which gives the doctor a signal to deflate the balloon, so that you give the heart a drink. Yeah.
But can you do it longer than 10 seconds? Can you do it again?
Yeah, you can do it again. So after one therapy, 10 seconds, give it a shot or a drink for like 30 seconds, and then you inflate again. And this is just an algorithm that they made. So before, for you to use an IVL, you have to use an NC balloon first, and if there's a failure, you go through the IVL. So now, using an IVUS, if you can see it's circumferential, the calcified area, just go straight to IVL. And these are some example of the cases. As you can see here, it's so calcified, and then after the IVL shockwave, you can see this artery is really big, and this one as well. Yeah. So you can see how big the artery was before it was calcified, and the same thing as here and here. So in here, it's a circumflex, ostial circumflex, so calcified. But after just giving several pulses, the balloon expands, and you can see that it's really big after the stent. And this is one of the examples as well. I remember this case actually. At King's, they were the first one to use shockwave like 4 years ago. And they did a CAD research study because this was a new technology before. So you need center to try this out. So King's was the first one to do it around 4 years ago. And as you can see here in one of the balloons, there's a dent there. That's so heavily calcified. So this is without yet a therapy. So after 10 pulses, you can see the balloon expanded, in there. And the same with proximal area. This is so very calcified there, around 90% stenosed. And after 20 pulses, it cracks the calcium, same as here. And this is the post-stenting. image. So in here, it's around proximal area. It's really calcified. And then after 40 pulses, it expanded beautifully. Yeah. And there. Yeah. And this is one from Professor Escaned of Spain. Before Shockwave, you can see the balloon. There's a dent there. And after 10 pulses, it started to expand. Yeah. And this one, I remember this case. So we use 3 Shockwave balloons at the same time. This is a trifurcation lesion. I remember this patient was in ITU for more than a week, and the patient was turned down by the surgeon. And so we use 3 Shockwave balloons at the same time there. And the patient was on LVAD, actually, as well. As you can see, their catheter. And after the Shockwave and stenting, you can see the areas fully expanded. And this is one example of the OCT. So this is a long axis view. This is pre-IVL. And you can see it's really calcified there. It's really bright. And it's circumferential as well. Yeah. And then this is after stenting. And after the Shockwave, you can really see that the stents are really well opposed to the wall, and the arteries become elastic now, so that you can expand the stent fully, which is great. I cannot pause this anyway. All right, we're gonna go now to the setup. So this is the Shockwave console. So after every use, we should put this back on charge, yeah, so that the next day we can use it again. It has a power button. This is the therapy button, and these are the charge ports. This is a charging port, and this is the port where you connect the cable. So the cable can be found in Rob's office, and also the catheters. So I got range of catheters here. So this, you connect this cable in here, and then this area needs to be sterile. So you put a probe cover, and then you cut the end, and you connect the catheter. Yeah, connect the catheter like that. It has magnets, so it just clicks. And then you pull the sonocide cover, so that you'll cover this area, and then you probably put a tape or whatever. So you turn this on. I don't know if it will detect this balloon. Oh no. So it says here, end of life of the catheter. Normally, once you connect, it will say how many pulses left. So if it's new, it will say 80 pulses. And then once it's ready, this will turn green. And then the doctor will expand the balloon to 4 atmospheres, and then he will press this. Yeah. And then it will give a click, 1 pulse per second. And then after 10 seconds, it's automatically shuts off. And as I've said, that will give a signal to the doctor to deflate the balloon, so that you don't occlude the vessel. Yeah. So it's a normal balloon. So before it's over the wire, but now they changed it to just a monorail. It has only 1 port, and that's where your inflator goes. And then standard balloon prepping, 50-50 contrast. You connect and then you neg, and then that's it. Very simple. Yeah. Okay. Any questions? So if you get like like red lights or amber lights, we have a paper here, a cheat sheet, and also you can find more details on the website. Yeah, I'm plugging it in, rodnieoro.com. You can see everything there. All right, any questions? Yes.
You said after the therapy, they need to inflate it to 6 and then deflate, right?
Yeah. Yeah. So initially 4 atmospheres, and then after 10 pulses, if it doesn't expand, you inflate it up to 6 atmospheres. And the rated burst is 10. So you don't go more than 10, otherwise the balloon will burst. Yeah.
6 and then deflate.
All right. Any more questions?
So it's not like it's gonna replace rotablation?
No. So it will take a lot of the cases from the rotablation because it's better. It's for the staff. It's easy to set up as well. No more IV fluids and less risky as well. Because with rotablation, there's a risk of the burr will stuck, and you'll be in trouble once that happens. And also there's a high risk of perforation as well in the section with rotablation. And also you need an operator that really knows how to use a rotablation. Not everybody can use it. From the get-go. Unlike with a Shockwave, that it's a normal balloon with a Shockwave. So even though you haven't used this, you can use it from the get-go. You cannot use this for everything because the smallest diameter of the balloon is 2.5, and there are arteries that's so small, smaller than 2.5. And for the rotablation, the smallest burr is 1.25. So yeah, so smaller than 2.5, you use a rotablation. Yeah. Cool.
Yeah.
Any more questions? Thank you. Thanks, guys.
Thank you.